Good afternoon, and welcome to the HFMA Colorado Chapter Virtual Fall Summit. I am Mike Brown of SCL Health and this year's treasurer for the Colorado chapter. I want to take a moment to first recognize our annual business partners who not only provide financial support to our chapter, but also share their knowledge and expertise through speakers and presentations. Their support allows us to operate our chapter and bring our members quality education and resources, especially through this challenging time. We hope you'll take a look at them first whenever your organization needs services or support. Our platinum sponsors are Athena Health, BC Services, Collection Center Inc., Continuum, Patient Co., PFC, PFS Group, Revenue Enterprises, TransUnion, and WHA. Our gold sponsors, AccuReg, BKD, Clifton Larson Allen, Credit Service Company, Healthcare IP, KeyBank, Plant Moran, and Guidehouse. And our silver sponsors, AppRev, Bessler, Brownstein Hyatt Farber Schreck, Colorado Health Facilities Authority, Coronis, Crossroads Health, Cyberscience, Hall Render, Para Healthcare Analytics, Strata Decision Technology, and Extend Healthcare. And our 2020 virtual sponsor this year is Commerce Healthcare. So thank you to all of our sponsors. For today's webinar, we will be using a Q&A box located at the bottom of your screen. Questions will be answered at the end of the session. A link to the download presentation will be provided in the chat box as well and sent after the webinar. If you will be requesting NASBA CPE certificate, please take note of the keyword, which there will be no keyword for this session. The speakers have already embedded Q&A, so for this particular session, you will not need a keyword. So presenting our speakers for CMS price transparency requirements, we have Jackie Nussbaum from Healthcare Performance Advisory Services at BKD. Jackie is a member of BKD's Healthcare Performance Advisory Service Division. She has more than 24 years experience, including 2 years at an academic medical center and 13 years providing consulting services with other large international accounting firms. Welcome, Jackie.
Thank you.
We also have with us today Jennifer Goins, Managing Consultant with BKD. Jen is a member of Healthcare Performance Advisory Services at BKD with over 19 years experience in healthcare, where 12 of those years were spent at 2 academic medical centers. So welcome to our speakers, and at this point, I will turn control over to you.
All right, thank you. Give me just a minute to get the presentation so everybody can see. And all right, I'm trying to make sure I've got the right screen showing for you here. Are you guys seeing anything yet?
I am not.
Okay. Just a minute here, sorry. Sorry, I'm trying to get my self back to the. All right, let me get off of this and go close out this. I think I'm getting closer here. Sorry, guys. showing up on my side, but I'm not seeing it for you guys. All right, let me know what you're seeing now. Can you see?
Yes, I can see
I
it.
can see that. Yeah.
Okay. Do you see the full screen or do you see like all the PowerPoint stuff at the top? Are you just
see
seeing the presentation?
I see just the slide. Yeah, the
Okay.
intro slide. Yeah.
Okay, very good. Sorry about that. And let me make our pictures smaller so I can see the whole thing for you there. So very good. Sorry about that little technical difficulty to start with. This is Jackie Nussbaum with BKD, as you heard there. And what we're going to go through is what we're calling answers to your frequently asked questions. So Jen and I have been working through price transparency since last year when the final rule came out. And over the past year, we've gotten lots of questions, and we've kind of been able to bucket those into common questions that we're hearing. So the way the presentation is laid out today is around some of those frequently asked questions. We will be keeping an eye on the question and answer box, and so trying to answer some of those as we go along if it makes sense to do that. Otherwise, we'll save some time at the end to try and answer as many questions as we can. We know this is definitely a hot topic. I was just sharing with these guys before that we had a HFMA national presentation a few weeks ago and had, I think, over 70 questions. So lots of questions coming in now as the deadline is looming here. So we'll go ahead and get started. And there's us. You don't need to see that again. Okay. So just in case you are you seeing where it says price transparency final rule?
Yes.
Okay, it's advancing on one of my slides, but not the other. So, or one of my screens, but not the other. So, okay. So in case you are still trying to work through the details and wanted to see where the final rule was, that's just the location of the final rule there. And then as you're probably well aware, since you're on this call, the effective date is January 1st, 2021 of the requirements that we're going to go through. We're going to start with the polling question. Our first polling question is, how prepared is your organization to meet the January 1st, 2021 price transparency requirements? Are you just getting started? Are you somewhat prepared? Well on your way? You'd say you're ready or you're not quite sure. Give you a few minutes to answer that. Getting close to our responses there. Okay. Very good. So here here are the results, and it's a little bit spread out here. A few of you just getting started, so hopefully we'll have some good information to share with you here to get you on your way. Those of you in the middle of the pack there, I would say that the folks we're talking to, many are in that that section there. That's awesome for those of you who are saying you're ready. I'm very impressed, and that's great that you've been able to get those requirements met at this point. So thanks for responding there. Go ahead and close that out. All right, so here starts our frequently asked questions. And so the first thing we wanted to go over was just to make sure everybody understood who has to comply with the requirements here. And so the first definition that CMS gives in the final rule is around a hospital. And so what you can see here is that basically the definition of a hospital, it's not based on your Medicare provider number. It really comes back to your state's rules and about licensing a hospital. So if your hospital is licensed as such, as a hospital in your state, then that would mean you're a hospital, and we'll talk about in a minute, who has to comply if you are a hospital. So that's the definition. Again, wanted to just make sure it was clear that it's not related to your Medicare provider ID. It really is how you're defined in your state. And then you can see there in that first bullet that this requirement is for all licensed hospitals. So you can see it pretty much runs the gamut there. It's your acute hospitals, your critical access hospitals, your psych, your rehab. There are really very few hospitals that are not needing to comply with this. You can see in the second bullet there are a few hospitals that are noted, and those would be your VA hospitals, your Indian Health Services. And the thought process there is why they're not included is those locations typically don't service the general public. So, and then you can see too in the last bullet there that entities that are considered non-hospital sites or ambulatory surgery centers at this point, those sites are not part of the requirement. We do get the question quite frequently, and we'll talk about this in a few more slides related to clinics, but we do get the question a lot of times about does a home health agency, does different components of your entity need to be included? And what we would do is refer that back to that definition of hospital. So as you're licensed as that hospital in the state, think about what falls under that license or that umbrella when you're trying to decide which entities might need to be included. Again, we'll talk about the physician piece, the clinic piece a little bit later and try and clarify that because we get a lot of questions around that as well. And Jen, if you see questions pop up, I know you're keeping an eye on those, so just feel free to chime in with those if they are kind of related to that slide. Okay, this slide, I really want to just take a couple minutes because we are continuing even to this day to have conversations with some hospitals who are not quite clear that there are two pieces to this requirement. And so just wanted to spend a minute to talk about the two different requirements, pieces to the requirement and what those entail. And then we'll get into a little more detail. So if you look at the left-hand side, every hospital is going to be required to put together this comprehensive machine readable file. And the way I like to think about that is most of you are probably publishing on your websites now from the January of 2019 requirement, your file with your gross charges. And so really this is taking that file and we call it on steroids basically. So now you're going to be creating that same type of a single machine readable file that's going to be published out on your website or your online location. And in that, you're going to not only now have your gross charges, but you're going to have all of these 5 types of standard charges that CMS has required. And we'll again get into those, but your gross charges, your payer specific negotiated charges, the discounted cash price, and then de-identified minimum and de-identified maximum negotiated charges. So again, every hospital is going to have to prepare this machine readable file. And then every hospital is going to have to put together a consumer-friendly shoppable services component. But in this piece, you have a couple of options. So the consumer-friendly, you may have heard that in the final rule, CMS has listed 70 shoppable services, what they call shoppable services, that every hospital is going to have to include in this consumer-friendly shoppable services requirement. And then on top of that, hospitals are going to have to identify 230 additional services to include, for a total of 300. The way you have options with this is you can either prepare an actual file, which could be, Excel, it could be, to your choice how you prepare that file. And again, it would be out there on your website. Or if your hospital has or is in the process of working through an online price estimator tool, that tool can take the place of the actual shoppable services file if it meets the requirements that are laid out by CMS. And basically those requirements are that tool has to include the 300 shoppable services. It has to be available on the website. A consumer can access that without putting in a password or anything like that. And then through that tool, the patient or the consumer has to be able to get their estimated out-of-pocket for the service they'll be receiving. So again, you have two options with this piece on the right, but you still have to do that comprehensive machine readable file regardless of that. So hopefully that's clear. But again, I do know that some hospitals we're talking to weren't familiar with the machine readable component. What items and services must be included? And so in the definition of the final rule, CMS has said that in your file, and we're going to talk about the machine readable file at this point for the next few slides, is that you would have to be including all of the items and services that the hospital provides, and then this concept of service package, what we'll talk about in a minute. And these are items and services that could be provided by your hospital to a patient, and this could be in connection with inpatient or outpatient services. And these are items where you have established a standard charge. And remember, a standard charge isn't just your gross charge, but a standard charge is your payer negotiated rate, the cash price, those 5 types of charges. So within your file, you're going to have to report on items and services that would include just, your procedures. You're also going to have to include supplies and pharmaceuticals. We know sometimes that information specifically around gross charges maybe doesn't sit right there in your CDM, that you have to go out to a pharmacy subsystem or supplies where you may keep more real-time pricing for those items. So you would be needing to go out and pull information from those subsystems. Also your room and board, any facility type charges you have. And then we'll talk about this more in a few slides, but the one thing that CMS has said too is that within your file, you will need to include services for employed physicians and employed non-physician practitioners. We get a lot of questions about this, so we'll have a whole slide on this in just a few minutes around what that means and what needs to be included there. And then basically any other items or types of services where the hospital has established a charge for those things. Okay. Here are the list again of CMS's 5 types of standard charges, and we read through this before, but the gross charge, and what we would say on this is really think about the gross charge being those things that are in your charge master. So that would be your starting point as to, and I've noted there again, anything that sits outside of the CDM, like the pharmaceuticals. This is not going to include any type of discounts. It really is going to just be your gross charges. And then that payer specific negotiated charge, these are going to be, and again, CMS uses the terms rate and charge interchangeably in this final rule. So when they talk about negotiated charges, what they're really saying there are your negotiated rates. And so really what they're going to be asking for is your negotiated rates with your different payers. And so we'll talk about that too, to say, there are payers where you may not negotiate your rates. And so those would not have to be included, but anywhere that you've negotiated rates. Again, we'll get into that a little bit more because we get questions around that. The discounted cash price, this, we get questions around this too, because that discounted cash price, this really isn't reflective of any kind of charity care or financial assistance that you would give to a patient. This patient could be coming in, they could be have insurance or have no insurance. That's not really part of the criteria, but really what it is you think about a patient who comes in and wants to literally pay cash for the service that they're having. And if they wanted to do that, do you offer some kind of a discount to them at that point of service when they are just saying, here's my cash, what do I owe? Do you offer that discount? So we get a lot of questions around that, so we can get into that a little bit more if there are questions there. And then the de-identified minimum and de-identified maximum negotiated charge, the way we think about this is you're going to go through this process of looking at your payer-specific negotiated charges, and then from that, afterwards, what you'll do is you'll array those things, and so you'll come up with the minimum for that, either a CPT code, the minimum for that service package, whether it's a case rate DRG, and you'll have to list what that minimum is and what the maximum is that you've negotiated. That piece is de-identified, so you don't have to actually put the payer name on that piece. Okay, which payers must be included, and do payers have to be specifically identified? I think we get this question and talk about this pretty much every single day. And what we would say is, again, that it's this is to include any of your payers, third-party payers, where you've negotiated the reimbursement. for either an item or service or a service package. And so we've listed here that if the hospital doesn't negotiate rates, so for example, your traditional Medicare, Medicaid, you don't have to include those because those are rates that are available on CMS's website. They may be available on your Medicaid, your state Medicaid website, and everybody's getting the same rate. Nobody negotiates those. What I do want to caution you is that if you have Medicare Advantage, if you have managed Medicaid plans where you're getting a percentage of Medicare or something along those lines, you really need to think about, if you're getting a percentage, did you negotiate what that rate was? And so CMS would say you would need to include those payers in your file. Even if your negotiated rate is 100%, if that's a rate that you may have a different rate than someone else because you've accepted 100% or you had some opportunity to negotiate, you would want to make sure that you get those included, and think through that same concept with all of your payers that you're going through and trying to figure out who is included and who is not included in this. We do get the question about, can we blind or dummy our payer names and just have payer A, payer B, payer C. And in the final rule, it does state that each of those, the payer and plan must be specifically named within the rule. So if you have a Blue Cross PPO, you would need to say Blue Cross PPO, Blue Cross HMO. If it has a different rate, you would need to identify that. So you can't really just give those things dummy names. You really need to say who the specific payer is. And then the last piece we get a lot of questions on is, do we have to report all of our payers? Can we just put our top contracts? And so what we would say there, what our advice here is that the final rule does not state that you can only pick your top 5 contracts, your top, those contracts representing 90% of your volume. There's nothing like that stated in the final rule. So what we would take from that is that CMS is expecting you to include all of those negotiated contracts. We've had lots of conversations, and we fully understand that you may have 200 contracts, but only 50 of those, really cover the majority of your business. What we would say is, as a hospital, you're going to just have to think through that and, determine on your own how you want to handle that. But I just want to make it, clear that there is nothing in the final rule that states a certain number or any type of volume for that. But again, we know that hospitals are having that conversation all the time. And Jen, is there a question?
Yes, we do. We have a question. And I would just, I know CMS has addressed this. So what about non-disclosure statements and contracts that say we cannot share those rates? Do you want to talk about kind of what CMS says on that topic?
Yeah, and this, if in the final rule, there's a lot of comments that have been made, and CMS weighing in on that, and that came up to say, we have verbiage in our contracts that states that we can't disclose certain information, and basically what CMS has said is that they feel that they have the authority within their confines to say that you can share that information. I would say if you have concerns about that, and a lot of people do have concerns about that, that's probably one of the biggest concerns, is that talk to your legal folks and figure out. Clearly the payers are aware that this is going to happen, and so I'm guessing there's been conversations with the hospitals, with the payers, but CMS has really said we feel like this is not a violation, that this information is out there and this is a federal requirement, and so you should be complying with the federal requirement. Okay. Okay, this one's kind of interesting because we've gotten the question a few times about why would we be required to report the payer-specific negotiated charge and clearly spell out who that payer is, but then also have the de-identified minimum and maximum. What's the point of that? And so the way what we're taking from this, and the reason we think this is probably happening, is that in the final rule, CMS has said there's those 5 types of standard charges. What they've said is that those 5 charges are severable from each other. So I think what they were trying to do is say, if the court were to come through and say, maybe a part of this rule is invalid, hospitals, you don't you no longer have to report your payer specific, but we still want to see the de-identified min and max. I think by doing this, it's allowing them that option to say, if one piece of this were to be invalidated, there's still other components of this. And if you think about it, to put together your de-identified min and max, you're really going to have to go through the exercise still of identifying the terms for your payer specific contracts. You just, if something were to change, you may not have to publish those. But I think that's the reason why there's, these 3 different components all within the same, requirement. Just real quick, what data elements for the machine readable file? Again, all hospitals are required to make this public, this machine readable file. We talked about that earlier, and include those 5 types of standard charges. Sometimes we'll get the question about, do we have to just say what our modeled or our contract term is, or do we actually have to model that out? And I've just got an example here to say, if your gross charge is $100, your contract is saying they pay 80% of charges. In your file, next to that line item, you would report $80 because you're getting 80% of that charge. So in most cases, what you'll have to do is actually show what that rate would be, not just the term. There's the file types that this could include. Again, as is with your current file, PDF is not an acceptable format there. And then again, you have to have that out there so that a consumer or patient isn't going to have to put a password in or pay a fee to get to the file. The last piece, just so you're aware, there is a specific naming convention for the machine readable file that CMS has in the final rule. It's pretty straightforward, but it is a requirement that your file has that name on it. So you can find that in the final rule, or you can ask us and we can get that to you. Okay. We get a lot of questions about, is there a sample layout out there? Is CMS laid out what this should look like? And I think the way we'd answer that is in the final rule, there is, for both the machine readable file and the shoppable services file, there's a table for each that gives you an example. What I would say that those examples are not very comprehensive. They're pretty basic, and for the most part, just show you the gross charge piece. They don't show you how to think through the next steps of how this is going to come together. What CMS has said is that you have the opportunity or the option to put that file together however you want, as long as it includes the required elements. So you can get creative with that. We've got an example on here. We're actually preparing this file a little bit differently now, but one way we're thinking about this is you may have, and this is for the machine readable file, you may have one tab that has your gross charges from your CDM. And then if you have a cash price, that typically the cash prices we're seeing are a percentage of your gross charge. So you could easily line that up right next to your gross charge. And then you could layer in there any payers that maybe pay you a line item that lines up specifically with the CDM. So a percent of charge, maybe a fee schedule, something that lines up like that. But then you're also going to have these items within your contracts that are not going to line up directly with your CDM. So if you think about it, you can see some examples there in that table. You may have a contract that pays you a per diem or a case rate, and those are services packages. And so those are to be spelled out separately. And you can see in this example here, we've got them at the bottom of this payer tab. And really we're listing out what in that contract is the term for a medical per diem or a surgical per diem. And so as you go through your contracts, you may find some commonalities that several contracts are paying you a per diem or a case rate for an ED visit, and you can line some of those things up. There may be some service packages that are very unique to one of your payers, and so that's going to end up having its own service package. And in that case, when you're putting in your minimum and your maximum charges, it would be the same because that service package is only provided by that one payer. So again, I think you just have to start through the exercise and try and figure out how you want to organize the information, but you do have your own ability to organize that however you'd like, as long as the required elements are included in there.
We have another question.
Okay.
Let's see if we want to take it at this time.
Okay.
So the question is, if you receive less than 10 reimbursement EOBs from an insurance carrier, would that require non-disclosure to avoid identifiers? So
So read it one more time, Jen.
if you receive less than 10 reimbursement EOBs from an
Okay.
insurance carrier, would that require a non-disclosure to avoid identifiers? My guess
Saying
is,
that you have, oh, go ahead, Jen, sorry.
I was going to say, my guess is this is similar to how CMS releases information that if there's less than, what is it, 15 or 12 of a certain subset of data, they
Yep.
don't end up releasing it so that they don't accidentally, I guess, identify or PHI, identify a patient. So I don't know, has CMS addressed this kind of concept within the final rule?
And I'm assuming this means related to the insurance companies that have low volume. And again, that goes back to saying that they've never, set a certain threshold or a certain volume limit. So the way we interpret that is that if you have a negotiated contract, and if you think about it, every payer is going to be identified in this file. So we would say you would need to include all of those unless your hospital makes a decision otherwise.
Let's take one more real quick since
Okay.
we're kind of on the topic. Do you have to include prices that were negotiated with concierge medicine clinics?
Is that if that's a negotiated contract, I guess that's where I would say, you have to think about that. Do you have a negotiated contract for those services? And I would say if you do, and you've negotiated a rate, you would have to include that in your file for those particular services that you've negotiated.
Thank you.
Is that what you were thinking,
Yes.
Jen?
Yep, that's exactly my
Okay.
same answer. Thanks.
So we're good for the ones we've
Yep.
gotten through so far. Okay, and I'm doing a quick time check here. Okay. This is one we get questions on also, and so I just wanted to make sure this is clear to everyone. We get questions about, okay, in our CDM, we have a time-based charge for our OR services, and you can see that top example there. So in your CDM, it may say surgery each 15 minutes, and you don't have a CPT code assigned to that because that's all, case by case. It depends on what the procedure was. It depends on how long the service was, as far as the total charge. So what you will report then in this machine readable file is that you're going to report your gross charges as reflected on the CDM. So in your CDM, if that's a time-based charge, that's what you're going to include, is that time-based charge, just as you see that there. And again, if you have a cash price, it's a percentage of that. That's what I've stuck in here, probably 80% of that. And then when you're thinking about your negotiated rates for those surgical procedures, in the example here, you may have a case rate for those services. And so a case rate, and what CMS has said on that is that a case rate, a service package is not necessarily going to have a gross charge attached to it in the machine readable file. So you don't set a gross charge for your case rate. You have a negotiated rate with your payer for that case rate. And so that's what you would be, providing for these cases where you have, in this example, a case rate for your ambulatory surgery. What you'd be doing is listing that on, if you were doing a separate tab for your service packages, you'd be listing that case rate and then the dollar value of that as you've negotiated that in your contract. So in this case, you can see that this payer has a case rate for ambulatory surgery of $6,750. That doesn't line up to your CDM because that's not the way you've negotiated that. And again, you don't have to line up a gross charge with the service package because you don't set a gross charge for your service package, and it could vary, as we were just discussing, based on the length of the surgery, the type of surgery, those types of things. So I know we get that one fairly frequently.
Yeah. We've got another similar question real quick to say, if you have negotiated rates with local entities like the local police or sheriff department, do we need to include those?
And again, I think it comes back to saying, have you negotiated that, or does everybody in town get the same rate? And truly, you guys will have to decide if if that's something where you have low volume, do you want to include that the requirement is that you include them all. But I would say if that's something that's negotiated, then yes, you would want to include that. And again, some of these you may only have negotiated for certain services. I think we were on a call earlier with someone who said they, for certain payers, only negotiate for emergency room visits. And so you may find that you're not going to be covering every single item or service that you provide with a certain payer, because you may have a subset of services with that payer. But we would say, yes, you would need to include that if you truly have negotiated what those rates are. Okay. We talked about this already, so I'll just skim over this one a little bit, but this is really going back to that idea of the two options you have for the shoppable services file. So again, you have the option to prepare a file, or you can put together this price estimator, or if you have the price estimator tool option. And most of the hospitals we've talked to are working with vendors. I would say probably 95%. We have talked to a couple of hospitals who are developing their own kind of homegrown estimator tools, but the majority, again, are working with some kind of, some vendor to prepare that file. And I'll just point out again on this, the file, the online tool, you do have to, again, that has to include those 300 shoppable services. So there's still going to be that piece of the exercise. And I know some vendors are helping hospitals with this. Other vendors are saying, you need to tell us your 300 shoppable services and then we'll build them out. So if that's the case, you're still going to have to go through this exercise to identify, how many of the 70 that CMS has laid out there do we provide? And then, how are we going to identify our additional 230 services? And that's going to really, in our mind, be that claims exercise where you're going to look through your claims data. You might look through your schedule of procedures that you schedule in advance, whether they're ORs or radiology procedures, and really get a good sense of what those services are. But I just wanted to make you aware, because we have heard that recently, that some hospitals have gotten caught off guard a little bit, because I think they thought that they were going to get a little more assistance from the vendors preparing or determining those shoppable services. And we've listed several vendors there. BKE doesn't have a tool, but we are, we know of some of those vendors that are, preparing those tools or have those tool options. The only other thing I was going to say on the shoppable services, if you're preparing that file, is that in addition to those 300 shoppable services, if there's services that typically have ancillaries associated with them, you'll need to make sure you include not only the primary service, but any ancillaries that go along with that primary service. And again, that's going to be, in our minds, an exercise to look through those claims and understand when you do have that primary service, what is typically going along with that. Again, you do have the flexibility. If you're preparing your own file, you do have the flexibility with what format you're using in that. I did want to point out too, because we get a couple questions on this with the file versus the online. The file itself, you do not have, there's no requirement in there to prepare out-of-pocket estimates for the patient. When the estimator tool, there is a requirement that the consumer would put in their insurance information and get that estimate of their out-of-pocket. Again, that's not going to happen in the file option. It will give the consumer, it'll show them what their insurance company is going to pay for the service they're going to have, but it's not going to allow them, they're going to have to know what they're on the hook for from the standpoint of their deductibles, their co-insurances, to really truly understand their out-of-pocket. Okay. We are at polling question number 2. Is your organization planning to use an online price estimation tool to meet the price transparency shoppable services requirement? Yes, no, or not sure? While you're filling that out, I'm not sure where things would stand from a national perspective, but I know from the hospitals that we've been talking with and working with, I would say we're probably about 50-50 on this piece. 50% are using and are planning to use an online tool, and 50% are preparing the file themselves. But I guess we'll find out how that compares with this group here in a minute. Okay, great. 56% of you said yes, you're using that online estimator. 15% said no, and 29% said not sure. So great. All right, I'm going to close that out. And then Jen, I'll advance because I think you're going to take over from here.
Yes. Yes, thank you very much, Jackie.
Mhm.
So we're going to go ahead and talk a little bit more about some of those elements that need to be a part of that shoppable services file. So again, CMS has not given an exact layout. As Jackie's mentioned, you can kind of choose how this wants to be, how you want to put this information together. The kind of bare bones requirements here are that there is a list that CMS has provided that is of 70 shoppable services. And then you are to provide those along with identifying an additional 230 shoppable services. If you look at that list of 70, which I know we've talked to some individuals, you may not provide some of those. If you don't, that is okay. You just need to find a replacement code to provide in lieu of those 70 shoppable services. Now on this data file, this only requires 4 of the 5 standard charges. So the one point here that it doesn't require is the gross charge. Now, that may still need to be determined depending on how your payer pays you. So if your payer is paying you at a % of charge, then yes, you're going to have to at least obtain and calculate or to get that gross charge, but you don't have to report it here on this file. And then again, this has to be identified down to that specific insurance payer plan, and to provide that information. A thing to note here too is that if some of these shoppable services are either there's a reimbursement difference or there's a setting difference, so it's offered in inpatient versus outpatient, or only at one campus, only at one clinic, that needs to be identified in that file. So if let's say you have some services that show up on that shoppable services list, or of the top 300 for you, and you're only offering those at one clinic location, then that subset needs to be called out so that a consumer would know which location those services would be available at. Let's go to the next slide. Okay. So here's kind of an example that CMS has released for what they would kind of envision a shoppable services file to look like. So I think this has been very helpful for us and also for some others when we've had conversations to be able to kind of take this whole shoppable services concept and try to lay it out and what does it exactly mean. So I'm going to jump to the middle of the slide first where it has an office visit. So that is one of the codes that that is part of that 70 from CMS. So this one is a little bit easier. This one, as Jackie had mentioned, lines up very easily with your CDM. And this is something that you can provide here. But if you look at the colonoscopy or the vaginal delivery that are on top or below that center service, you can see that there's a lot more components here. So this would be like those service packages that Jackie's been talking about. So when you have a colonoscopy, there are other charges that go along with it. The anesthesia, maybe some labs, potentially pathology, and then also there could be those physician services that would go along here, which we're going to talk about here a little bit more, I think, on the next slide or two. And in this scenario, indicating that those physician services are not provided by the hospital and that those could be billed separately. And again, if we look at the lower one, which would be the vaginal delivery, you can see how this is laid out. So thinking about those, there could be labs, there maybe is an ultrasound charge, there's some epidural, there's some, other drugs, some other things that kind of, some supplies, those kind of things. So trying to look at your claims to see what is common that is billed together so that you're able to provide that on this list. Jackie, did you have anything?
There was a question. No, okay. There was a question that said if a patient could be outpatient or inpatient and they gave a joint replacement as an example, would we have to show both on the shoppable service? Or they said we would have to show both on the shoppable services list, correct? And we would say yes.
Yes. Yes, I'm assuming because you're probably going to get 2 different reimbursement methodologies for how those are going to get paid. So yes, let's go on to the next slide.
Okay.
So here's, I feel like, $1 million question that we get quite frequently is, do you have to include professional charges? So what CMS has said is services that are of employed physicians and employed non-physician practitioners, so think your NPs, PAs, that basically all of those services kind of constitute that professional charge. They need to be included, but CMS hasn't defined what employed means. And it's really up to the hospital and what is your organizational structure to kind of walk you through to determine if you need to include these charges. So one of the things, we kind of walk through like a little bit of a decision tree when we talk to hospitals about this to say, do you have employed providers? And if they say yes, then the next question that we would ask is, does the hospital establish and negotiate those charges for those professional services? Do they bill for those professional services? Are those charges maintained in maybe the hospital CDM, or maybe it could be a different system, but the hospital maintains that? Does the hospital receive the payment and retain that payment for those professional services? So if you start answering yes to those questions, then yes, we're going to say those employed charges for those employed providers, those physicians, or those non-physician practitioners will need to be included as part of this requirement. And similarly, then the question is, do we include clinic charges? And again, we would say, let's walk through that decision tree again. So as Jackie mentioned earlier on, how CMS has defined a hospital by that state licensure. So then are those clinics is that state licensure covering those clinics? And if yes, those could be on campus, those could be off campus, they could be provider-based rural clinics, and then also layer on that, do those locations have those employed providers? And if yes, and you answered yes to those previous questions, that you do negotiate, you do set their charges, you do bill and retain for that payment, then yes, those charges would also need to be included here in this kind of the clinic portion of these data files.
And Jen, I'll say this just because this
Yeah.
always comes up in the same type of conversation is, again, as you go through these and make these decision points, just keep track of them, memorialize them
Yes.
somewhere, make a list of, okay, we decided these are the components, we have to include our home health agency. We're going to, for this reason, we're going to include, or we're going to exclude because we don't think this is applicable. Same thing for your clinics and your professional charges. Just, kind of make a note of decisions you make throughout this process and why you've made those decisions. That's our advice.
Yes. Yes, absolutely. Thank you for adding that, Jackie.
Okay.
So I know we get this question quite frequently too, to say that some people are listening and saying, what if I don't want to do this? What is the penalty for non-compliance? And so CMS has laid out the following kind of items and how corrective action would be identified and would occur. So if CMS is made aware, and I believe they've said, and correct me, Jackie, if I misstate this, but I believe they've said they're not necessarily going out and on January 1st and checking every hospital's website to find this.
Right.
But if a patient is looking for the information and can't find it and reports it to CMS, then this is when you might hear from them. So the first time you would get a written notice that the hospital is not in compliance. They would require or request that you provide them a corrective action plan, and that you're going to meet those requirements. And then if it's you're still considered to be in non-compliance, then there is a civil penalty, a monetary penalty of $300 per day for non-compliance. So they also have said that they can also make public the list of hospitals that are not compliant or that are not in compliance with this. So I think, I know for some facilities, when you figure out what's $300 a day for a year, what is it, like $109,000 roughly?
Yeah.
We've heard from some facilities that are saying, we'll take the penalty and we'll pay it. I think you need to have a big conversation about this, not only, from the financial impact, but also from the public image, your PR, your marketing, how this would look if this is made public and, it gets on the front of a newspaper in your town that you are not compliant with this rule. So lots of things to consider here. Again, as Jackie mentioned, I think if that's the route you're going, make sure that's memorialized and everyone that needs to be involved in that decision has been included in that decision. So
and
I see
I was going to go, yep, there's a couple questions. These go back to our previous slides, but this one says, in your decision tree, do you include only hospital-based services? And I think this was going back to, trying to figure out kind of what's in and what's out. And so again, what we would say is start with thinking about your hospital, how your hospital is licensed as such and what falls under that umbrella. And so then if you have hospital-based clinics, whether they're on campus, they're off campus, if they're rural health clinics, if those things fall under, your hospital license, easy for me to say, licensure. I still didn't get it right. Those things would need to be included. So when the question says only hospital-based services, if they're meaning, on campus, off campus, those types of things. Again, if it falls under the hospital umbrella, we would say those need to be included. And then, Jen, were you going to say something on that one?
No, I think the next question might further clarify it. Is just saying, I think that question is a hospital-based. It's if it's a physician-only practice, that's not a hospital-based facility.
And it doesn't fall under the
right.
employed physicians or under the hospital umbrella. Yes, we would say
right.
if it's, and I don't know if you guys can all see the questions, but it says if the service is not performed in a hospital-based location, but as part of the 70, would you consider this to meet? Is my understanding medical group, non-hospital locations are not included in the requirements. So what we would say is you're picking your 300 services, you would think of whatever falls under that hospital umbrella. Right. So, if you've got a provider-based clinic, whether it's on campus or off campus, if those fall under that hospital umbrella, you would look to all of that to pick your shoppable services. But yes, if you've got a medical group or a practice that doesn't fall under the hospital umbrella, then you wouldn't be including or need to look into that data to be part of your 300, if that makes sense.
Okay, I think we're ready for the next slide. I know I'm keeping an eye on the time, so
I know I was just looking. Hopefully we're getting the questions at least that come in. I think we've gotten all those as they've come in. Okay.
Yes. So let's do polling question number 3 right now. Has your organization considered paying the $300 per day penalty instead of complying with the requirements? Yes, no, or not sure?
Jim, we may have to scooch on because we've got 8 slides still to go here. Actually, probably less than that. But.
Okay. So it's about 74% said no, and 15% said yes. So very interesting. I think this kind of varies kind of based on the size of the organization and kind of based where people are regionally, I feel like. So all right, let's go ahead and close that out and then let's move on. So this here is something that we want to clarify. So because I know there has recently been a lot of confusion around this, we got a lot of questions. How does the price transparency requirement relate to the 2021 IPPS final rule? So here's kind of a backstory. So there was an article in Becker's that had some information about this. it seemed to commingle these two different rules. And so we reached out to several colleagues and to HFMA National, correct, Jackie, and
Correct.
clarified that these are two independent, two separately different rules. So the question really was, if my hospital decides to not comply with the January 1, 2021 OPPS price transparency final rule, will I no longer receive Medicare payments? That answer is no. And as you can see in this table below, there are two separate rules here. So the top one is from the 2020 OPPS final rule, which is what we have been talking about here in doing your machine readable and the shoppable services file. That compliance date is January 1st, 2021. If you're not in compliance, you could have a penalty up to that $300 a day. The second portion of this in that bottom row is the 2021 IPPS final rule. That is where the requirement is that the hospital must report on their cost report the median payer-specific negotiated charges for their Medicare Advantage plans. And that starts with cost reporting periods ending on or after January 1, 2021. And that is the requirement, that if you do not comply and put that on your cost report, that is where you could no longer receive Medicare payments. So I think some of the confusion came here. A lot of the exercise that you are doing for the January 1, 2021 rule for the machine readable and the shoppable services file is going to get you very close to the information that you're going to need to start reporting on your cost reports related to those Medicare Advantage plans and those payers. But no, if you do not comply with the January 1, 2021, that does not mean you're no longer going to get payments from Medicare. Now this,
and we were just gonna, oh, go ahead, sorry.
I was going to say the one other thing is the cost report portion of this is not applicable to critical access hospitals. That's correct, Jackie, right?
Right, yes,
Yes.
that's what I was gonna say.
Okay.
And I know we have like 3 minutes left.
I
so
know, I'm going to
I don't
try
know
to,
that we need
so
to.
you'll have all of these slides in your slide deck. So these kind of last ones are just things to consider of making sure of the teams and the people that you need to make sure you're preparing these files, and things to consider as you're getting everything ready to release on that 1/1/2021 date of service. So let's move on to the next one. Here's a kind of a readiness checklist that you can look through. So things to think through, making sure if you need to look at your pricing strategy or how you need to get your files prepared, and make sure that you have everything available and out on your website. And then this one gives me a little anxiety when we look at it. And I modified this slide, so I should know that. But as we're getting closer and closer, this is kind of, a timeline that was laid out on where you should be in your process. So we are getting, very close. We're almost at 65, 66, maybe rough days until the deadline needs to be met. So it might be a little late to look at refining your pricing strategy now, but not too late to get your information and try to get those files created to have those available. And then this last slide here is just thinking through some of the things like what we're doing here at BKD is helping with those machine readable files, helping with shoppable services files, as Jackie had mentioned. Some of the vendors aren't able to or aren't going to be helping determine those 300 shoppables. So that can be a component of it as well. So I know we have like 1 minute left. Is there any last questions? I know we ran through those last slides very quickly.
I think we've got all the questions that at least came in on the
Yes.
Q&A box.
Yes.
Well, Jackie and Jennifer, thank you so much for the great information. It was incredibly helpful. I just want to say to our attendees, be on the look for surveys The surveys for all of our sessions will go out on Friday at the conclusion of the entire event. So be on the lookout for those. If you can complete that for us, we would greatly appreciate it. Your feedback's incredibly important while we're planning our future events. One other note, if you're attending the CHA State of the State session tomorrow, please be aware we're adjusting the start time to allow for a transition from the previous session. So we'll actually be starting that session tomorrow at 12:05 p.m. instead of 12 o'clock. And that concludes our session today. So thank you all so much for joining us.